Hello, and welcome to this RPTH Research Recap, where we dive a little deeper into the science being published at RPTH. I'm Kirsten DeWitt. I'm a research scientist, an emergency physician, and a thrombosis physician based in Canada at Queen's University. I have the pleasure of interviewing Dr. Anna Parks. Dr. Parks is an assistant professor and director of thrombosis in the Division of Hematology and Hematologic Malignancies, and a Center for Aging faculty member at the University of Utah. She is a physician scientist whose research focuses on improving outcomes for patients with non-malignant hematologic diseases. Dr. Parks has published a manuscript in RPTH entitled Use of Single Whole Leg Ultrasound to Exclude Deep Vein Thrombosis in Pregnant Patients. For those who are joining us on Facebook, Twitter or X, and YouTube, please leave your comments below, which will be answered during the discussion. So we're going to start by handing over to Anna, who is going to present her research findings.
Great. And thank you so much, Dr. DeWitt and the RPTH editorial team for inviting us here today to share our results. We're so thrilled to get to talk about this paper, which has been a long time in the making. It's really an honor to share these results. I'm here on behalf of all of my co-authors, and although I'm at the University of Utah, all of my co-authors listed here are from Intermountain Health. And I am indebted to them for all their work on this project over many years and for giving me the opportunity to share our work today. So today I'll be talking about excluding pregnancy-associated deep vein thrombosis with whole leg ultrasound. So just as background, deep vein thrombosis is increased in pregnancy. It occurs in 1 out of 1,600 pregnancies, and it's associated with both adverse obstetrical and fetal outcomes. DVT can occur in isolation, and it, of course, can also lead to pulmonary embolism, which is the leading cause of maternal death in Western countries. And at least in the US, as we know, maternal death rates have been increasing recently. So this is an important public health issue to be addressing. Unfortunately, evidence-based diagnosis of DVT or deep vein thrombosis in pregnancy is challenging because pregnant patients have traditionally been excluded from studies evaluating diagnostic strategies. And that's because many of the signs and symptoms differ between pregnant patients and non-pregnant patients because of some of the physiologic changes of pregnancy, such as lower extremity swelling that can mimic DVT. And lab changes, such as changes in D-dimer that occur in pregnancy. As a consequence, data on the best diagnostic strategies for pregnant people is limited. As background, there's, of course, several different modalities that clinicians can use to diagnose deep vein thrombosis. Ultrasound is one of the commonly used methods. So most often, ultrasound is confined to the proximal veins, which is on the left-hand side of the screen here, which is essentially the veins that are closer to the torso, so the common femoral and popliteal veins, which have the highest risk of embolization. And that's depicted here in this picture. In this study, we used whole leg compression ultrasound, and this captures images from the pelvis to the ankle, meaning from the iliac to the calf veins. So whole leg ultrasound can detect both proximal and distal deep vein thrombosis. And large studies by my co-authors have shown that a single negative whole leg compression ultrasound in all comers can safely and reliably exclude suspected both proximal and distal deep vein thrombosis in the general population, but very few pregnant patients were included in these studies. For example, there was a large meta-analysis of about a dozen studies that was published in 2010 that included only about 57 pregnant patients. Clinical prediction rules are another way of evaluating the pre-test probability of deep vein thrombosis, and they can inform whether further studies are required for the diagnosis of deep vein thrombosis. And as this audience probably knows, there are many clinical prediction rules for deep vein thrombosis, but unfortunately, they have limited applicability in pregnancy. For example, the Wells clinical prediction tool includes things like recent surgery and cancer history as highly predictive of deep vein thrombosis, but those are much more uncommon in pregnant patients. So they have much less sensitivity in this population. Fortunately, the LEFT clinical prediction rule for DVT diagnosis and pregnancy has been developed in this population and externally validated, but its performance has not been previously evaluated extensively in external populations. It has 3 clinical criteria that are depicted here. So the L in the left stands for deep vein thrombosis symptoms in the left leg, which is more common because of the position of the gravid uterus that alters flow on the left side. The E stands for calf vein circumference 2 centimeters larger in the symptomatic leg. And then FT stands for first trimester of pregnancy. So to address these gaps in knowledge, we conducted a prospective study to evaluate the 90-day rate of DVT in pregnant patients suspected of DVT using both of these methods. So using a single negative whole leg ultrasound. And then we also calculated the elements of the left clinical prediction rule to further explore its performance in pregnancy. So patients in this study were recruited between February 2011 and April 2019. And we enrolled pregnant patients who were referred to a tertiary care hospital for suspected first episode of deep vein thrombosis in the vascular ultrasound lab, which is where all patients suspected of deep vein thrombosis are referred at this center. Patients who had a prior DVT or who had technical challenges in performing an ultrasound, who were unable to follow up based on where they lived and similar issues, who couldn't provide informed consent, who were currently taking anticoagulants or who were planned to use anticoagulation were excluded. And before any kind of diagnostic modality was employed, these patients underwent a focused history and physical exam by a clinician to verify the study inclusion criteria, and then also to calculate the components of the left clinical prediction score. And subsequently, all of that clinical information, including the left components, was blinded. So in all, 194 patients were screened and 189 patients were deemed eligible and enrolled as shown in the figure here. Following enrollment, all 189 patients underwent a single whole leg ultrasound of the symptomatic leg. 186 patients had a negative ultrasound. Those patients did not receive anticoagulants, and they were followed for 90 days. They were instructed to contact their treating clinicians or the study staff with any new or progressive symptoms that were consistent with thrombosis. 4 patients who were enrolled were found to have a deep vein thrombosis on their initial whole leg ultrasound, and they were excluded from follow-up and further analysis and were managed by the treating clinician, and all 4 of those patients received therapeutic anticoagulation. And then all patients were followed for 3 months using both phone calls as well as review of the electronic medical record. And importantly, due to the lack of specificity of D-dimer during pregnancy and in line with clinical practice guidelines at the time that the study was designed in around 2011, 2010, patients did not undergo initial screening with D-dimer. So our results, so the mean age was 30 and the mean BMI was 29.5. A little over half were in the third trimester, a third of patients enrolled were in the second trimester of pregnancy, and the remainder were in their first trimester of pregnancy. These patients on average were in their third pregnancy, and the range was between first and 13th. So just to go a little bit more into our outcomes. So 17 or 9.2% suspected of DVT in 90 days underwent a repeat ultrasound. I'm sorry, the arrow is not showing up there, but it's just saying that 17 patients underwent a repeat ultrasound in the 90 days following enrollment. Of those 17, 2 were diagnosed with a deep vein thrombosis. Both of those patients had a femoral deep vein thrombosis of the left leg. One of those occurred on day 6 following the initial negative ultrasound, and the other on day 9. 2 patients were suspected of pulmonary embolism. However, their computed tomography pulmonary embolism scan was negative for pulmonary embolism. There were no deaths. Importantly, no patients were lost to follow-up. All patients completed a full 90 days of follow-up. And also, no patient received therapeutic anticoagulation for another reason during the course of the study, so all patients were able to be analyzed for the primary outcome. With regard to the left clinical prediction score, so one patient in the study did not have leg measurements entered, so there were 189 patients among those initially enrolled for whom a left score could be calculated. In 86 patients, 45.5%, none of the left criteria were present, and 1 DVT occurred in that group during the initial ultrasound. So that's 1.2%. In 83 participants, 1 of the left criteria was present, and 2 DVTs occurred in this group during the initial ultrasound. And then in 17% participants, 2 of the left criteria were present. 1 DVT occurred in this group during the initial ultrasound, and both of the subsequent DVT events that occurred in the 90 days of follow-up following an initial negative ultrasound were in this group. Only 3 participants met all 3 left criteria, and none of those participants had a deep vein thrombosis. The 1 patient who was not able to have their left score determined due to the lack of the leg measurements did not have a deep vein thrombosis. And so in the 103 women with at least 1 left criterion, the proportion diagnosed with deep vein thrombosis was not significantly higher. And so in summary, the area under the curve for the left clinical prediction tool in this population was 0.649. And as a consequence, the resulting sensitivity of a negative left score was 83%. The specificity was 46%. The negative predictive value was 98%. And the positive predictive value was quite low at 4.9%, which unfortunately is cut off on the slides here. So in conclusion, as you may have noticed, this is a small sample size, and the stop date was in April 2019. So an important caveat to our results is that this study was interrupted prematurely due to the COVID-19 pandemic. And so as a consequence, we have some imprecision in our results. But nevertheless, we think that the findings are informative in part because, as we'll discuss a little bit later, I think, of how difficult it is to perform studies in this population. So 2 things I hope to emphasize to the audience, and I'm looking forward to hearing your thoughts. But first, in this prospective cohort study of pregnant patients presenting with signs of deep vein thrombosis, the 90-day risk of symptomatic VTE in those with a negative initial ultrasound was low, 1.1%, when anticoagulation was withheld. And while the study didn't attain full power, the observed rate of DVT suggests that the use of a single whole leg ultrasound can exclude DVT in pregnant patients. It may be safe, even in the context, as we'll talk about, I think, a little bit more, of a very low baseline prevalence of disease. Secondly, these results provide additional evidence that the left clinical prediction rule is accurate at discriminating between women at low and high risk of deep vein thrombosis with an AUC of 0.649%, which is on par with, although slightly less impressive than the results that were found in the initial external validation of this risk score. So in conclusion, larger prospective studies are needed because of the low prevalence of DVT in our study, which is very common, as I mentioned, among studies of suspected DVT in pregnancy, and because of the unfortunate premature closure of the study. In particular, we think that what we've hopefully demonstrated is that a single whole leg negative ultrasound could be combined with additional diagnostic strategies, such as the left clinical prediction rule or biomarkers, including the D-dimer, as has been done in more recent diagnostic studies of VTE in pregnancy, to improve the sensitivity of these diagnostic modalities. All right, and with that, that concludes my discussion of the results of our study, and I am very happy to take any questions from those joining us and from Dr. DeWitt.
Thank you so much, Dr. Parks. You've really provided some essential evidence on this patient group, which has so little evidence in existence. So really a meaningful contribution to the literature.
Great.
I was wondering if you could explain a little bit to the audience about how a whole leg ultrasound differs from a proximal leg ultrasound, and whether you would be able to extrapolate the findings from your study to centres who conduct only proximal ultrasound for deep vein thrombosis.
Yes, absolutely. So I think it's a very important question, and I think I mentioned in the beginning that typically, as you said, ultrasound is of the proximal veins, and that's in all comers. And the reasoning behind that is there's many reasons, but one is the potential for overdiagnosis of distal DVT and overtreatment. And some of those distal DVTs don't progress to become proximal and thus don't have the same risk of causing pulmonary embolism. And as you know, many guidelines, although this is changing, don't necessarily advocate for treating distal deep vein thrombosis. And so as a consequence, many centers moved toward both that cost and time reasons as well. Many centers and training needs for ultrasound technicians, many centers moved towards proximal ultrasound. So Intermountain Health, the center where this study was conducted, and then many other centers around the country instead use whole leg ultrasound. And that's, as I mentioned, been shown to be useful in all comers in excluding deep vein thrombosis. The reason is that for distal deep vein thrombosis, and again, we're getting into the technical details here, but technical clinical details. For distal thrombosis, many guidelines now advocate for serial ultrasound, which has a lot of limitations. Many patients are unfortunately lost to follow-up. It's, again, additional time and expense, at least in our fee-for-service system. And so as a consequence, some, I would say, thought leaders have advocated for whole leg ultrasound. And I would also mention that pregnancy, and I didn't say this initially, but it's important, the location of deep vein thrombosis in pregnancy is actually different than in all comers as well. Pregnancy is more likely to be associated with thrombosis of the pelvic veins, which is actually quite difficult to image. And so whole leg ultrasound is able to image the whole leg, and so has increased sensitivity for all thrombosis. And so as a consequence, it's thought to be more sensitive in pregnant patients, but also in all patients. And so it's really a sort of a implementation issue as opposed to its diagnostic utility. So what I would say in answer to your question is that it's been shown in other large studies of all comers that even though it requires additional technical training for ultrasound technicians, it's feasible to perform whole leg ultrasound on a large scale, at least nationally in the United States. And that's been shown in some of the studies done by the senior authors on this paper, Dr. Stevens and some of the other authors. I think if whole leg ultrasound isn't available, then you are in the situation where probably the guidance from ASH, the ASH VTE guidelines and several others, including the CHEST guidelines for serial ultrasound, which is also advocated by ACOG. And so I don't think you, so the main takeaway is I don't think you can extrapolate these results of whole leg ultrasound if you're only using proximal ultrasound, because you may miss distal DVTs that then progress.
Yeah. Okay, thank you. And your study did not use D-dimer.
That's correct.
I was
Yes.
wondering whether you have any thoughts on D-dimer for deep vein thrombosis testing, or is that just, really an unanswered question still?
Yeah, so I'll be honest, I was in medical school when this study was started, so I had to read up about why this was the case because, as many of our listeners are aware, subsequent diagnostic strategy clinical trials and studies, for example, the YEARS algorithm that was published in the New England Journal recently for pulmonary embolism in pregnancy did employ D-dimer. And so it's actually kind of a historical reason why D-dimer was not used in this study, which is that we know that D-dimer physiologically rises with each trimester in pregnancy. And so at the time the study was designed, the jury was really out about the clinical or diagnostic utility of D-dimer for diagnosis of deep vein thrombosis in pregnancy. So as I mentioned, subsequent studies have successfully used it, and they've used a cutoff that's higher in later trimesters and lower in earlier trimesters. And so, as I mentioned at the end, I think now that basically the clinical evidence supports that D-dimer can be successfully employed, we think that combining something like an ultrasound with a biomarker that's now been validated, like D-dimer, would increase and improve the sensitivity of a whole leg ultrasound. And that adding a clinical prediction rule like left would be even more helpful.
Yeah, excellent. So this study took 8 years to recruit. Can you comment a bit on the challenges of conducting venous thromboembolism, particularly diagnostic research in pregnant patients? And do you have any thoughts on how in the future, we could approach this challenge and try and overcome the issues?
Yeah, and I would be eager to hear your thoughts as to Dr. DeWitt, because I know this is an area that you're an expert in. So as I said, I came to this a little later, and I really do have to thank my co-authors on this study who included me because they know this is an area where I think there's a lot of disparities in research, and it was truly a labor of love for them. So the big issue with these studies is that although the risk of VTE in pregnancy is increased, the actual prevalence is still quite low. And so you need a huge sample size to complete these types of diagnostic studies. And then, as I mentioned before, part of the issue, and then part of the reason the prevalence is so low is because, and this is probably a good thing, clinicians have a very high baseline suspicion of deep vein thrombosis in pregnancy. And so the number of ultrasounds that you need to complete, for example, to diagnose a single VTE is higher because the clinician's suspicion is high. And then I mentioned too that the symptoms of pregnancy and the physiologic changes of pregnancy can overlap with especially DVT symptoms, but also pulmonary embolism symptoms with increased shortness of breath as pregnancy progresses. So for that reason, I think this is a perfect opportunity for networks of researchers to establish multi-site studies, as challenging as that can be. I think this is for all, just like all quote unquote rare diseases, this isn't a perfect example where consortia are key. And so I think hopefully this is a call to action that although this was a very well-designed study with dedicated investigators, still, because of essentially slow accrual and then the COVID pandemic, the estimates are quite imprecise. And so we hope that these results are sort of hypothesis generating and provoke people to perform those types of larger studies despite the legwork that's required. That was an unintentional pun, but yeah.
Yeah, okay, thank you. And then just on a closing point, so most deep vein thrombosis diagnosis studies have excluded pregnant patients over the years, over the last few decades.
Yeah.
And can you maybe talk a little bit about whether, because we have evidence for testing for deep vein thrombosis in people who are not pregnant, is it safe to extrapolate those results, do you think, to pregnant patients, or do we still have to hold out to really test out the best approach in pregnant patients?
Yeah. And I mean, I think if there are OBGYNs listening in on this, I think they would say that this is an issue with research in pregnancy generally. There's a lot of issues with conducting studies in pregnant women, pregnant people, unfortunately. So for many of the reasons that I've already stated, but I'll just reiterate them, in the absence of evidence, I think that's the best we can do is extrapolate from non-pregnant people. But there's clearly differences in the risk factors and the presenting signs and symptoms. And so, for example, the Wells criteria for calculating pretest probability of deep vein thrombosis in pregnancy, it includes things that are just really not present in pregnant women the majority of the time, like cancer and surgery. And so as a consequence, it's really not applicable to apply that type of clinical prediction rule in this population because your sensitivity will be quite poor and you will have many false negatives. It's a sort of a catch-22. I think it's really the best we can do, but this should be a priority. As I said, in my country, in the United States, maternal morbidity and mortality has been rising over time, which I think most people would agree is an unacceptable situation, given the resources we have available to us here. So the challenges of research in this population, I think, shouldn't be a barrier to doing these studies. It just has to be prioritized. In the meantime, I think our best option is to extrapolate, but there's clearly huge issues with doing that in these patients.
Thank you so much, Dr. Parks. It's been a real pleasure to speak with you about this important paper. I think it's time for us to draw the session to a close. Thank you so much to the audience for joining us live. And don't forget to follow us on Facebook, Twitter, X, and YouTube. And thank you for watching. Keep an eye out for our next RPTH recap. Goodbye.
Thank you so much.